Clinical features of patellofemoral pain syndrome. How does actually this disease presents? As you know that they are actually associated with the knee pain. Pain is first and the foremost symptom, but usually this pain is not constant. There is always, it could be intermittent or persistent pain. Usually there is always a dull aching pain which is actually not severe enough that it hampers patient's daily activities. In our case study, she was actually a dancer and she continued to dance for 6 months. Now you can very well imagine if this pain would have been severe enough, she would have consulted doctor earlier and she would not have been able to continue dance during her normal activities. So usually the pain is dull, less severe. It could be intermittent times which may get aggravated by, for example, certain activities like dance. Our patient is going to a movie theater and sitting there for prolonged time with his or her knee bent, or during the sitting or squatting activities, or in the activities in which he or she is actually climbing stairs. There may be an aggravation of the pain for a little bit of time, but usually it's dull, low aching pain, which is kind of sometimes it's intermittent, sometimes may persist for a prolonged period of time. But usually these patients have a history of about 3 to 6 months to 8 months of a pain which has been on and off for a prolonged period of time. But the pain is still the major or the most important symptoms. It's actually, as I told you, that symptoms may get aggravated by certain activity. Usually patients complain that whenever they are doing certain activity, most commonly it's associated with climbing stairs, sitting, squatting, that this pain actually gets aggravated. And once they take rest or they take certain analgesics, this settles down for a bit, but it's not completely gone. It's never finishes, but it does settles down so that they can continue with their daily activities. Then the next thing is swelling. Over the period of time, this swelling also waxes and wanes. Sometimes when they are having a days in which they have to use their knees quite a lot, for example, they have to climb stairs for a quite long time, or they have to do it quite a number of times a day. This may result in some degree of swelling in the evening at the night, and eventually once they take rest, this eventually wanes off and swelling actually decreases over the period of time. So swelling is sometimes it's not massive swelling, it's actually some degree of swelling which actually persists and waxes and wanes over a prolonged period of time. Whatever the symptoms are, actually for example, if you are seeing a patient with meniscal injury or ACL injury, the patient actually just cannot stand and patient cannot actually continue, and there is definitive problem, and patient actually presents quite earlier, within days to weeks. And with ACL injury, patient cannot just get up and start playing, therefore they just present right away just after the injury. Therefore, it is important to understand that if the patient has taken about months to actually present with these sort of symptoms, likely the problem is either less severe and it's less likely to have some kind of a meniscal or ACL PCL injury, rather than it would be more towards the ligamentous strain or sprain or patellofemoral instability problem, or it could be patellofemoral pain syndrome. Therefore, usually the threshold is our presentation is a bit subclinical kind of presentation, in which the patient has problems, but it goes away at times. There is an intermittent set of problems, so he or she is actually continuing with her activities of daily living. Then comes the malalignment and tilting of patella. Usually, as I told you, the most commonly underlying cause is also measurable malalignment syndrome. Therefore, you have to understand that examination there could be malalignment or tilting of patella, or you can appreciate the patella is going more laterally because there is increased patellar instability. Now, patellar instability itself could be contributing to this patellofemoral pain syndrome, or this could be the resulting patellofemoral pain syndrome would have resulted in patellar instability. Both sides things can happen, go sometimes hand in hand. Other is cortisol wasting. For example, these patients have actually quadriceps wasting because they usually do not use it properly, or sometimes what happens is that over the period of time, due to prolonged rest they've taken to relieve themselves of pain, this results in actually the weakness of the quadriceps, and there may be some signs of quadriceps wasting as well. Then there may be fluid in the knee as well. Patients usually suffer from effusions of the knee because with chondrocyte damage, there may be increased inflammation in the knee. With increased inflammation, there is increased production of the synovial fluid, and this may present with increased knee fluid or effusion of the knee. And usually, as there is a chronic case of this disease, this effusion may be at that sometimes the only symptom when the patient may present to you with certain problems. Our patient at that time may have a very slight degree of a pain, but mainly the patient may have the knee effusion only. Physical examination when done on these patients, this usually shows that there may be some degree of tenderness. Mainly it's also called as anterior knee pain syndrome. Therefore, on palpation, mainly the tenderness is on the anterior and the medial aspect of the knee joint. But usually there could be some degree of swelling and tenderness over the parapatellar region, that is on the anterior, medial, or the lateral aspect. Sometimes you can also elicit that there may be associated patellar instability signs as well. For example, J sign may be positive as well, or there could be, with the history of certain injury, there could be ligamentous injury to such as medial patellofemoral ligament injury, or there may be weakness of the quadricep muscle or vastus medialis obliquus. Usually the first and foremost sign is whenever the patient is asked to extend the knee joint against resistance and you palpate the patella and push the patella backward, this usually results in increased knee pain, especially over the anterior aspect of the knee joint. This is the most common clinical finding which you usually see on the knee examination. Other findings may or may not be present. Usually all these tests for meniscal injury or ACL, PCL injuries such as Lachman or anterior draw are usually negative. There may be some degree of parapatellar or superior medial or superior lateral aspect of the patella. Some degree of swelling may be present, and which the patient may elicit signs of certain knee effusion as well. But usually the most common and the most important sign is that there is actually increased patellar tenderness, and it's on palpation when especially the knee is extended against resistance. Here other signs are usually negative.